Welcome to Module 2. Previously, we looked at what health data is and how it is defined and managed. In this module, we'll take a deeper look into health data and how it is used. A survey of nursing and midwifery staff about perceptions of data quality was conducted previously. The aim of the survey was to find out if people could relate their role in patient care and the data collected with some of the other services within the hospital and externally to the hospital that consume the same data. Let's take a moment to examine the results. Down the left axis, we see the type of data usage, for example, patient care. Each of the coloured segments represents the sum total of responses for each scale item. By way of an example, you can see that the gold colour represents all the strongly agree responses. There were a few responses of strongly disagree and disagree when considering the use of data for health fund billing and service costing. Interestingly, there was quite a strong response of no opinion on these topics as well. There were comments that said that these activities were finance related and or not part of delivering patient care. The most positive responses were for patient care, which is no surprise there, and medical research. These results do highlight that there is a bit of a disconnect between data collected for patient care versus other areas of the hospital that use it. It's really important to be aware of how data is used across the hospital. Data quality begins at the point of capture. If data is not captured completely or accurately, then it will have flow-on effects. The best opportunity to find and fix issues with patient data is while the patient is receiving care. It becomes a real challenge and costly exercise to try and fix data issues once the patient has been discharged. Let's examine this a bit more. So how is data used in healthcare? 1. To manage the continuity of care for patients. 2. To streamline healthcare services and delivery. 3. To efficiently manage hospital and healthcare service delivery. 4. To monitor healthcare costs and service billing. 5. To inform health system policy. And 6. To ensure consistently high quality of care. We saw in the video in simple terms how data flows through a hospital. Each arrow on the diagram is data moving from one clinical or service function to another. Whether it's a paper chart, diagnostic imaging or pathology results, data flows from the first point of patient contact until the patient is discharged. And data continues to flow after discharge, with reports sent to Queensland and federal health departments. What is important to understand is, once data has been entered into a computer system, it is immediately available for any area within the hospital that needs it. If the data is incorrect or incomplete, or delayed in entry, then it affects all other areas who need it. For example, if the incorrect patient URN is recorded on a pathology result, then the treating clinician may make the wrong diagnosis and treatment. If a baby in the NICU receives drugs that are incorrectly recorded, then there is a risk of overdose. If a patient's religion is not recorded properly and they receive treatment that goes against their beliefs, then this becomes an issue. All of these are examples that have occurred at different times. A study of 248 cases of EHR-related health IT incidents published in the Journal of Patient Safety found that 63% of issues related to user issues. The nature of the problems range from mistypes relating to a hybrid, i.e. paper and digital record, to mistakes caused by copy and paste errors. As a personal reflection on the importance of accurate data in health, I am reminded of a story about a cancer patient who was undergoing high-dose chemotherapy and radiation treatment. In preparing for a second high-dose radiation treatment, the treating doctor asked if there were sufficient stem cells in the cryogenic bank. The staff checked the records on the computer system, which indicated cells were available, and the procedure went ahead. During the procedure, the requested cells could not be found. Tragically, the patient passed away as a result. An investigation found that the computer system had not been correctly updated after the first treatment to show there were no cells left. Let's take a little look at how hospitals are funded. The introduction of activity-based funding means that public hospitals receive funding based on meeting performance targets established by the government. The number of each kind of clinical service is set each year based upon case mix data provided by hospitals. Money provided by the state and federal health department is contingent on achieving these targets. If service data isn't recorded and reported correctly, then the clinical coding can be affected. It is the clinical coding that drives hospital funding. Other funding sources include private health funds, co-funded, where the patient pays for the non-Medicare covered expenses, and generous donations from benefactors. The diagram on the right represents public health service funding for the 2013-14 year based on Medicare data. High-quality data is critical for successful medical research, but a study in 2018 revealed that Australian medical researchers spend too much time accessing and processing data. This is largely because there are different information systems, different data standards in play between different states and federal agencies and healthcare providers, making interpreting health data a challenge. The MyHealth platform is an attempt at providing a standardised way of reporting and recording data. But for it to be fully useful, more healthcare providers need to connect and send data, and the kinds of health data supported need to be expanded. The diagram above is from the Association of Australian Research Institutes and provides a snapshot of medical research projects, clinical trials, and the investment in terms of funding and the benefits to medical science and patients. We've come to the end of Module 3, so as a bit of a wrap-up, health data is used in a variety of ways within a hospital. Data flows from one clinical service to another. Data also flows out to external health authorities. Public hospitals receive funding for services based on activity. Accurate data reporting is required as part of operating a health facility. That last dot point is very important. Accurate data reporting is a licensing requirement. For example, HCP and ANSNAP data must be reported within 42 days from discharge.